Good evening, everyone. Today we are going up with the topic that is most interesting, whether you are in the ER or ICU, that is POCUS, point of care ultrasound. Today's speaker we have from Turkey, Dr. Erol Unluer. He is the board member of Emergency Physicians Association of Turkey, that is EPAT, and also he's the president of Sono School International Network. He's the president of Made Easy Network, that is madeeasycourses.com, which helps medical students. And he's currently serving as the HOD and educational responsible at the University of Health Sciences, that is in the, I'm sorry, I'm able to
Izmir.
translate, that is in the Turkey itself. So,
Yes.
So your screen is visible, sir. You can start.
Okay, thank you, everyone. And I would like to extend my appreciations to my presidents, Dr. Srinath Kumar and Dr. Saravana Kumar, and all of my distinguished Indian colleagues. As this great introduction emphasizes that I am emergency medicine. I am a professor of emergency medicine, and I am the president of Made Easy Lifelong Learning Courses, which is accredited in 55 countries of the all over the world. And also, I am the founder and president of the International Sono School Network. And this is up here. You can see my hopefully my new hospital. Next month we will move to this hospital, and this is one of the biggest hospital in Europe, among the biggest hospitals in Europe. And this is the city where I'm living in now. Is in the aging part of the Turkey. And again, welcome to this interesting lecture. And if you go on to PubMed and drop my surname and my first letter of my names to see how many publications I have done about the point of care ultrasound, you can easily find a lot of publications in relevant scientific journals. And after this small introduction, 20 years ago, 30 years ago, when we are young, everybody was against emergency physicians and was against intensive care physicians to use ultrasound and echocardiography in their clinical experiences. But nowadays, after last decade, American Heart Association, American Society of Echocardiography released a consensus statement and told that focused cardiac ultrasound in emergency setting should be done for the patient's care. So it is generally accepted after that time. And but we shouldn't forget some important point about this topic, because you should be experienced, and also you should have significant training and knowledge, and you should have good diagnostic skills, and also you should use this tool as a non-echocardiographers to augment, to increase your clinical ability, assessment, and diagnostic abilities based on physical examination alone. So don't forget routine steps of medicine while you are evaluating your patients. And why this topic is so important in emergency department and intensive care departments, because if patients remains hypotensive in ED or ICU, every hour for hypotensive state, the patient's morbidity and mortality will increase at least 10%. So you should be very quick to decide whether this patient needs volume or whether this patient needs a drug treatment to increase their blood pressures in emergency department. So We know that already. We know that 50% of the hypotensive patients in emergency department cannot give positive response to fluid challenge. When you give fluid them, you cannot increase their blood pressures 50% of the time. So after that, you should go to the drug treatment, vasopressor treatment immediately, as soon as possible. So you shouldn't waste any time. So if you find some answer to your questions, this patient needs fluid or this patient needs drug treatment as soon as possible, that is the gold question and gold answer in your patient's evaluation. So what we will talk about a brief summary for Doppler physics, and we try to understand how the Doppler works in ultrasound machine. This is the first part of the lecture. And then after that, how we use this physics and this Doppler use of ultrasound in the IVC and other decision-making instruments or lung and heart interaction and dynamic parameters for hypotensive patients in the management. And at the end, we will analyze some brief cases to sum up all the lecture. So let's start with the physics. As you see from the picture, this is a very well-known example for Doppler physics education. There is some person here, a stationary observer, and an ambulance coming towards the observer, and you will see an increased strength of the ambulance siren while it is coming towards the observer. If this ambulance goes away from the observer, stationary observer, you will see a decreased strength of the ambulance siren, ambulance voices while you are observing this. And this is a very well-known example, and everybody knows. This is the schematic view, how we get this in real life. This is the stationary person, observer, and moves away, an object moves away from the stationary observer, and you will see the frequency in the each ultrasound beam will increase when the moving object goes away from the observer, and also the wavelength increases. But if the object moves towards the observer, this time the frequency between the ultrasound waves, ultrasound beams will decrease, and also the wavelength decreases. And how we see in the schematic diagram this problem, here a moving object towards the transducer has a decreased frequency, and it is different than the originally emitted ultrasound frequencies and wavelengths from the probe. So the transmitted frequencies and the wavelength are different than the received echoes, wavelength, and frequencies. And this causes a velocity change and also a frequency change and also a wavelength change. So the velocity of the originated echoes from the probe are not the same as the returning echoes, velocities, and frequencies and wavelength. And this is called as Doppler shift. So because of this Doppler shift, we can easily find the velocity of the object, either going away from the transducer, or we can find the velocity of the object going towards the transducer footprint. So if we put all of these in the formula, you can see that we also use the cosinus of the angle of the transducer. So this is important because when the angle of the transducer goes up over than 60 degrees, it will be closer to the zero. And if you put a zero value here, you will achieve again a zero number. So the velocity will be zero if the angle of the transducer closer to the 90 degrees angle. So you should be parallel as much as you can while you are measuring the velocity of blood flow. This is very important. Because of that, we are trying to be parallel as much as the blood flow. So because of that, in transthoracic echocardiography, we are using apical 5-chamber view or apical 4-chamber view to get this angle less than 60 degrees. So what is the bottom point is that the 60 degrees is the most upper level of the accepted angle in the Doppler measurements. So you should be parallel as much as you can with the blood flow. Please don't forget that. And if you see the Doppler image on the ultrasound screen, if you activate a Doppler mode on the ultrasound image, you can see this type of graphics. This is a spectral waveform graphics. All of you most faced encounter with these waveforms. As you see, we have x-axis here, and we have y-axis here. X-axis represents the time, and y-axis represents the velocity. But actually, this is not two-dimensional graphic. Also, we have third dimension in this graphic we can evaluate. It is the inside of these waveform angles. As you see the inside in the middle, you will see the black area. And the sides of the triangle seen as white areas, echogenic areas. Okay? What does it mean? It means that I can evaluate a blood flow, how the blood flow here, and the quality of the blood flow. Because if you see a black area, empty area inside the triangle, and the echogenic white areas around the triangle, it means that this is a laminar blood flow. If you see this, assume that this is a blood vessel and this is the side view of the blood vessel. The velocities in the middle is bigger than the velocities at the sides because the blood cells touches to the walls and encounter with the resistance of the walls, blood vessel walls. So in this area, the velocity is less than the velocity here in the middle. So this is called laminar blood flow. And you will see this representation in the Doppler as an empty area in the middle, black, and the white area around the triangle. That means that this blood flow is laminar blood flow, not turbulent, not stenotic. If you have a stenotic blood vessel, what you will see in the middle, you will see also white areas. Okay? Everybody is with me? Is there any question? If you have any question, you can easily ask me and interrupt the lecture to ask. So when I take a look at this picture, I will see the time, I will see the velocities, and also I will evaluate this blood flow is laminar or turbulent or stenotic. And also, if the blood flow towards the transducer, I will see the positive deflection of the wave, just like ECG. If the blood goes away from the transducer, I will see negative deflection below the baseline. So what I have evaluated, I have evaluated velocities, I have evaluated time, I have evaluated the direction of blood flow, and also I have evaluated the blood flow quality. Either it's laminar blood flow, normal, because the empty black area, or stenotic blood flow. So this is the Doppler principles. Okay, and I can measure the velocities, and I can measure the time. If you multiply the velocity with the time, you will get the result as distance. So if you multiply the velocity with the time, you will easily the distance at the end of this equation. Now, let's look at this laminar blood flow again. What I told you that the blood cells close to the side walls has decreased velocity than more decreased velocity than the middle blood cells. So in this area, the blood cell velocity is higher than the side blood cells. So in order to measure the velocity of this blood flow, all of the blood flow in that area, I will take integral of this area. What is the integral? If you collect the pieces results, and if you go to the whole of the triangle, you will take the integral of this part. So if you want to calculate the blood flow accurately, you should take the integral of this area, because this area velocity is not homogeneous. So machine will do this instead of you, and if you envelope this area with the machine, it will give you the velocity time integral also in this Doppler waveform graphic. Yes. So the people, based on this knowledge, produced two kinds of Doppler in the ultrasound machine. One of them is the continuous wave Doppler. The other is the pulsed wave Doppler. These are two different Doppler modes in the ultrasound machine. Continuous wave Doppler, what does it, how it functions? There are two crystals divided by two. One always transmitted the sound, and the other part of the crystal received the returning echoes from the targeted object. This is the continuous wave Doppler. And it measures all the velocities along this, across this way. But in pulsed wave Doppler, you have a gate here or here, whatever you put, you have a gate, and you will collect the sample only from this gate. And you have one crystal here, and produces ultrasound beams, and also receive the ultrasound beams with same crystal. And you should collect the sample of a targeted area when you drop a gate here. So this is two different kind of Doppler used in the clinical area. And these are the Doppler's advantages and disadvantages. We use continuous wave Doppler when the valve have a pathology with high velocity. If your patient's valves are diseased, injured, or turbulent, and if you have high velocities, you will use continuous wave Doppler. Don't forget this. If your patient's valve has normal, native, not turbulent, not stenotic, native valve, and you want to do some calculations, now in this time you will use pulsed wave Doppler. So If you want to measure with high velocities, for example, a patient with aortic stenosis, you should use continuous wave Doppler. If you want to measure one patient's cardiac output, in this time you will use pulsed wave Doppler with a normal valve. So if you memorize this, you will easily do everything with these Doppler modes. Again, this is the schematic diagram. On the left side, we see apical 5-chamber view, RV, LV, RA, and LA, and this is the aortic root. And I have a gate now. What is this? Pulsed wave. I put my, now in that picture, I put my pulsed wave at the tip of the aortic valve, and I know that this is a normal valve. Now I will do my measurements. I can measure time. I can measure maximum velocity. I can measure the velocity as a whole during each beat. Okay. And I can say that the blood goes away from the left ventricle to the aortic root and away from my transducer here and away from the transducer. So I will see below the baseline, this triangle, and I can see the black areas here and the white borders here. And I can say that this is a laminar blood flow and pulsed wave gate Doppler, and I can do all my measurements. And I am along the way of the blood flow from the LV through the across the aortic root and parallel. Okay, let's go. Look at this. Again, I put my Doppler here, apical 5-chamber view, aortic root, away from me, as you see, away from me. Each beat, with each contraction, with each systole, blood goes away from transducer, blood goes away from transducer. With each beat, you see black area, white borders. This is a laminar blood flow and not pathologic valve, native valve, good valve, good. And with each beat, you see the blood goes away from left ventricle with each beat, and I see a negative deflection. Yes, let's go. Now, this was the first part of the lecture. If you have any question, please don't hesitate to ask me. And after this brief summary for Doppler, now we will go how to use this Doppler ultrasound on real patients in emergency department and intensive care department. And now we know that why this is important in our clinical assessment. Everybody knows that inferior vena cava, and all, I'm sure that everybody look at inferior vena cava now in their departments. And all of we know that the inferior vena cava collapses during inspiration because the blood comes from the inferior vena cava to the heart, and we see a collapsed inferior vena cava during spontaneous inspiration. And in expiration, because of the diaphragmatic pressure, the inferior vena cava dilates, and every respiration cycle, so breathing in and out, we see the inferior vena cava collapses and dilates. If you see no collapse during inspiration, and if you see no respiratory movement of the inferior vena cava, and also if you have a patient with hypotension, you can easily say that the reason of this hypotension and shock is above the diaphragm. If intrathoracic pressure increases or intrathoracic volume increases, as we see in tamponade, congestive heart failure, pulmonary embolia, pneumothorax, hypervolemia, it causes a dilated and no collapsible inferior vena cava. So when you see a patient with hypotension, first check the inferior vena cava, and if the inferior vena cava dilates, you will go above the diaphragm to search the diagnosis, such as tamponade, pneumothorax, pulmonary emboli, or hypervolemia. If you see a collapsed IVC with hypotensive patient, you will search at that time blood loss for this patient, either below the diaphragm or above the diaphragm. So the inferior vena cava is really important. How you can find the inferior vena cava with ultrasound? You can use phased array probe or curved array probe for this application, and you should put the transducer, your transducer sagittally in the middle of the abdomen. In the middle of the abdomen, you should put sagittally and under the kyphoid process of the sternum, and at that point, if you go 1 centimeter to the right side toward the liver, you will get rid of the aorta, and you will see the inferior vena cava under the left lobe of the liver, connected to the right atrium above the diaphragm. This is usually what we do in our emergency departments in hypotensive patients. And also, as I said, there is a respiratory movement of this IVC in normal, spontaneously breathing patients. And to calculate or estimate the CVP of the patient by checking this diameter of the IVC, and also by checking its collapsibility on inspiration and expiration until now. And this, as we see from the picture on the presentation, if you find an IVC less than 2 centimeter in anterior posterior diameter parasagittally, either with the M mode or B mode, and if you see more than 50% of the collapse on inspiration and expiration, that means that your patient's central venous pressure is less than 5 millimeter mercury. And when you go down, you will see, if you see a patient's IVC more than 2 centimeter and minimally collapsed during inspiration and expiration, your patient's CVP is between the 15 and 20 millimeter mercury. But if your patient's IVC more than 2 centimeter in anterior posterior measurement, and also dilated with dilated hepatic wings and no collapsibility during respiratory cycle, that means that your patient's CVP is more than 20 millimeter mercury. And you can decide that this patient needs fluid, or this patient needs drug therapy to get a good blood pressure. But the literature showed us that, yes, it is valuable, but when you see the IVC diameter less than 2 centimeter and collapse percentage is more than 50%, that means that your patient's right atrial pressure is less than 10 millimeter mercury. If your patient's IVC is more than 2 centimeter and collapse percentage is less than 50%, it means that your right atrial pressure is more than 10 millimeter mercury. What that means? That means nothing, because that's just a number, just a number that I have picked by measurement. But this will not give you anything about the compliance of the heart and heart response to any fluid challenge or any drug treatment. So this type of measurements of IVC will not give me anything about the patient's response to my treatment. just give me a number. Also, we can use these calculations in the collapse to get the collapsibility index of the IVC. How we find the collapsibility index of IVC? The maximum diameter minus minimum diameter of the IVC divided by the maximum diameter of IVC multiplied by the 100. It will give you a collapsibility index. And from all times, we know that more than 80% of the collapsibility index means that this patient can give a positive response to fluid therapy. But this is studied, and we now know that the situation is not like that, because this IVC measurement will not give you any idea about the heart performance, heart compliance, cardiac compliance, and will not give you any idea about the lung compliance also. While you are afraid of pulmonary edema of the patient during your fluid challenge in this hypotensive patient. So we don't know anything about any end organ of our targeted treatment when we are measuring the IVC in these patients. Yes. Now, let's go with the case. This is a real case. Come to my emergency department and let's evaluate this case. 30 years old female patient admitted to ED with a complaint of dizziness with hypertension, 60/40 millimeter mercury with tachycardia after a period of gastroenteritis. So look at this. This is a real patient's image. This is the right atrium, left lobe of the liver, and we see a very tiny IVC collapsed less than 2 centimeters. That means that this patient needs fluid or medication. I'm asking to you, fluid or medication? Yes, this patient needs fluid to increase her blood pressure. Now, let's look at this case. Again, the liver, the inferior vena cava, right atrium, parasagittal plane, anteroposterior diameter, and I am sure that this is the IVC and changes its diameter with in response to respiration. And this patient on the left side, according to me, needs fluid, of course. But if you look at this patient, you see the hepatic vein going through the left lobe of the liver is dilated. And also the IVC is dilated as a pipe, lead pipe. And this is the right atrium. Now, no good collapsibility during respiration, just like a lead pipe. And in this case, to increase his blood pressure, you should give medication rather than the fluid therapy. But as I told you before, one measurement is nothing, and it will give you nothing. So what can we do now? Because we should decide whether this patient needs fluid therapy or whether this patient needs drug therapy as soon as possible to increase the blood pressure of our patients. So you should check the dynamic parameters of your patients. What I mean dynamic parameters. And is from medical schools, you can easily remember your medical schools. This is the Frank-Starling curve, and this is stroke volume, and this is the preload. If you increase the preload of a heart, your stroke volume will also increase if your patient's heart works good. Until now, until the limit of compliance of your patient's heart. After this limit, it doesn't change anything whether you should give hundreds and hundreds of fluid to this patient after this plateau. So you should catch your patient during the steep curve of your Frank Starling picture. So you should catch your patient here. If you give fluid to your patient in this area, that means that your patient's stroke volume and cardiac output will increase, of course. But if you give fluid here in this plateau phase, you cannot increase your patient's blood pressure effectively. So you should go to the vasopressor in this area. So after evaluating this Frank-Starling curve, let's look at this, what is happening in spontaneous respiration in the patient. During inspiration process, we produce negative pressure intrathoracically. So we take our breath in, and this taking breath in will increase the venous filling of the right side of the heart. And because of the bigger right chambers during inspiration, and also bigger sizes of the lung because of the inspiration, that causes an obstructive effect over the left ventricle. And at the end, you will see a decreased cardiac output of the left side during inspiration, and during expiration, you will see the increased cardiac output in spontaneously breathing patient. Let's recall our Doppler physics. What I told you, when you measure the velocity, and if you multiply the velocity with the distance, velocity with the time, you will easily get the distance of the ultrasound beam. Okay, don't forget this. Velocity multiplied by time equals to distance. And assume that this is a bottle, and this bottle is filled with the water. And if you try to find the volume of the water, what you will do, you will calculate the area, bottom area, this circle. And if you multiply this circle, this area with the height of the bottle, you will easily find the volume of this bottle. This is very important. Now, let's apply this mathematical equation to the heart. This is, as you see, parasternal long axis view of the heart, and you will see the RV, infundibulum of the RV, interventricular septum, LV, and aortic root, and left atrium. As you assume that this aortic root is a closed bottle, just like this. If you find the area of the bottom, and if you find the height of the bottom, you will find the volume of this bottle. So now what I will do, I will calculate the area, this chamber, and I will calculate the distance of this bottle to get the volume of the blood pumped with each beat. That is stroke volume. What is stroke volume? The blood volume pumped out from the left ventricle with each beat is stroke volume. Now, after calculating the circle area, if you measure this velocity multiplied by the time, that means velocity time integral, you will easily calculate the volume of this bottle, stroke volume. And if you multiply this stroke volume with the heartbeat of the patient, you will easily get the cardiac output of the patient. Actually, as a summary, what I'm talking, what is this? This is the blood flow with each beat of the systolic. So this is actually a visual representation of stroke volume of the patient. 1, 2, with each beat, this much of blood, this amount of blood pumped out from the aortic root. This is stroke volume. This is stroke volume. And if you multiply with heartbeat, this stroke volume multiplied by heartbeat, you will achieve cardiac. Yes. Now, let's see this video. You will see the apical 5-chamber of this heart. This is the RV, LV, aortic root, RA, out of plane, and LA. Okay, now what we will do now? Now, what we will do? Yes, go. That's it. That's it. Yes. Now, what we will do? First, I will get a parasternal long axis image, freeze it, and I will measure the radius of aortic roots. And with this calculation, pi multiplied by the LVOT diameter square and divided by 4, this is the aortic root area. The machine calculates it automatically instead of you. So if you put the measurement of aortic root on the parasternal long axis view, it will calculate it, the LVOT area automatically, and you shouldn't do anything. So the machine will calculate this instead of you. So after this measurement, now this time, I will do measurement of velocity time integral. I will go to the apical 5-chamber view. I will put my gauge here at the tip of the aortic valves on apical 5-chamber view, and I will see the blood pumped from the ALV to the aorta negatively with each beat. My transducer here in apical 5-chamber view, and I will envelope to measure the velocity time integral of this waveform. So if I multiply this with the aortic area, I will find this stroke volume, and at the end, if you multiply it by the heart rate, you will easily calculate the cardiac output. Now, heart rate can change. Okay, so you can easily rid of the heart rate. Yeah, you can. It is better not to count heart rate. Also, it can change with pain. It can change with fever. So heart rate is not important for cardiac output change. So every time with each calculation, also the aortic root area will not change. It is constant. Okay. So what is the rest? What is the most important? The most important thing is the stroke volume, is this velocity time integral with each heartbeat, because the aortic root not change and heart rate can change to another condition for pain and fever or something else, anemia, but this always depend on the blood flow from the heart. So this is the most important thing, velocity time integral for our measurements. So this is the cardiac output, but forget this. Yeah, just I have told this because it is better to learn or it is better to know how to do it. But please don't use, because it's useless. Measurement of the cardiac output is useless. What we will do now? Now we have some magic formulas. Until now, during this lecture, you can easily forget everything. But please don't forget this slide. Please take a photograph of this slide. This is the magic calculation: maximum minus minimum divided by mean. What is mean? Max plus minimum divided by 2. Mean is that. So this is the magic formula. And this is the magic numbers for measurements. If you measure the IVC, maximum diameter and minimum diameter during respiration, if you put in this formula, if you find more than 12%, that means that this patient is fluid responsive. Okay, this is called distensibility index. If you are working with the stroke volume, velocity time integral, if you measure your patient's velocity time integral values, and if you put in this formula maximum velocity time integral minus minimum velocity time integral over mean, if it is greater than 20%, it means that your patient is fluid responsive. If you measure the maximum velocity of your blood flow from aorta, and if you put these numbers in this formula, and if you find more than 12%, that means that your patient has fluid responsive. So please memorize this formula and these numbers, and for you, this lecture is finished. But we will see how we assess our patients without using anything, only by using our eyes at the end of this lecture. But if you have to memorize a formula, please memorize this formula. Now, let's analyze this. This is a pulse wave Doppler dropped over an apical 5-chamber view at the tip of the aortic valve. And you will see with each beat, 1, 2, 3, 4, 5, 6, 7, 8. With each beat, this much of blood flow pumped out from the left ventricle. Now you can easily find the minimum velocity here, maximum velocity here, if you want to calculate maximum velocities. And you can easily put these numbers into the formula, and if it is greater than 12%, that means that your patient has fluid responsive, just by looking at maximum velocities and minimum velocities. Okay. And if you measure not maximum velocities, if you measure the integrals of these two different waveform, and if you put it in the formula, and if you find that greater than 20%, that means that your patient has fluid responsive. That means that with each respiration, that much of blood comes to the heart of the patient, and it increases the stroke volume of the patient because of the respiration. Just like giving 500 fluid to your patient, and it increases your patient's stroke volume and cardiac output 15%. This has been studied multiple times. So it's in the literature. So if you see a patient like that, okay, that means that your patient has fluid responsive. Whether your patient are on mechanical ventilating device, not spontaneous respiration. So this is the use of IVC distensibility index formula and the fluid responsiveness of the patient. Max minus minimum divided by the mean. And if you have greater than 12%, that means that your patient has a positive response for fluid challenge. And I am sure that your brain is mixing now. I don't know. burned or not. But let's analyze in more simple way. Okay, now let's look at the more simple analysis technique. Now forget everything for the lecture. Okay, now I will show you how we will do this. This is the patient. I'm sorry, I have written 30 years old female patient, but she should be 60 years old female patient. Hypotensive tachycardia, same patient after gastroenteritis. And this is a real patient, and you have seen that the heart like that. You see, there is no good motion of the anterior valve, mitral valve leaflet, and it comes and goes a little bit, okay? That means that this patient ejection fraction is very low, and also the area changes in of left ventricle not so good. So this patient ejection fraction is good, not bad. And also you have measured that IVC is again more than 2 centimeter and approximately less than 50% collapsed. But if you look at this patient in apical 5-chamber view, and you will see with each beat, with each respiration, she changes her stroke volume beat to beat. If you come from here at the Vmax of your first image and connect the Vmaxes of the image, now here you see there is no linear, fine, soft line. It goes up and then down, then up, then down, undulating movement. So always connect the tips of the velocities by your eyes. If it is not linear, undulating, that means that this patient needs fluid. If you see this connection line is just goes straight, not undulating, that means that your patient needs vasopressor therapy, not fluid therapy. Now let's look at this together. Again, another case, pulse wave, normal valve. I am here, my transducer here, aortic valve, at the tip of the aortic valve goes downward, deflections away from me, and I am sure that this is aorta. And also I have seen that the black areas in the triangle, laminar blood flow, and I am sure that I should use pulse wave Doppler. And now this patient assume that hypotensive and connect the tip of the velocities of these patients stroke volume with each beat. You see a straight line. You have got a straight line, not undulating line when you connect the tips of the velocities. That means that your patient needs vasopressor, not fluid therapy. But look at this. This patient is also hypotensive, and you drop your pulse wave Doppler across the aortic valve, and now you will connect the tips, undulating from one to another, not straight line. What does this patient needs? This patient needs fluid therapy, my brothers. So if your patient hypotensive, and if you connect by your eye the tips and undulating, if you get undulating line, that this patient needs fluid therapy. So this is rather mixed algorithm for intensive care physicians, how you cover fluid challenge or drug challenge for your patient in the intensive care. If you have a patient either mechanically ventilated or not spontaneously breathing patient, you can use distensibility index always. You can use velocity time integral formula. You can use Vmax in this patient. But if your patient has no triggering effect on your mechanical ventilation device, okay? If you have a triggered, if you have a patient with triggering of your device, so it is better to go to the lung to see your patient's lung, wet or dry. So if your patient has some breathing movement on mechanical ventilation, go directly to the lungs. If he or she has no triggering on mechanical ventilation, just connected to the machine, please go to the VTI, Vmax, pulse Doppler, connect the lines of the velocities, and also you can use IVC distensibility index. At the end, let's remember how we see the wet lung on the ultrasound. You will see the upper rib, lower rib, pleural line, and the B lines. Means that your patient's lung is filled with fluid and no need to fluid. Please restrict the fluid and start the drug therapy. Yes, this was the end of my brief lecture of fluid responsiveness in emergency department and intensive care unit, and I can take now questions.
Yes, so there's one question. So how can one assess the intravascular volume of a patient with pulmonary embolism as there are raised right heart pressures, bearing in mind that the raised pressures will cause the IVC to be dilated? And it might be interpreted as raised fluid overload. How do you assess that?
Now, as I said before, thank you for this question, of course. As I said before, no application in medicine without any limitations. We have also some limitations in this area. If you have a question in your mind, and if you are not sure that, for example, which approach you will take, now my recommendation is that go to the end organ, as I said. For example, if your patient has a pulmonary emboli and you want to assess your patient's fluid status, whether he is dry or wet. In this case, directly go to the lung. Okay, lung. If you see more than 2 points with V lines on one side and more than 2 points on other sides, it means that your patient's lung is filled with the fluid. So you should restrict your fluid. In pulmonary emboli, we can sometimes see the B lines at the periphery because of the parenchymal infarct. But in that case, the patient with light pulmonary emboli, okay? If you see the peripheral B lines locally presented, that means that this patient has not severe, mild pulmonary emboli. But if you see the B lines on both sides, that means that the fluid must be restricted in this patients. On the other side, what was the next question? Sorry, what was the next question?
Yeah, I mean, the raised IVC, the engorged IVC might be felt like it is because of fluid overload.
Mhm. We use we use IVC at the extremes. If it is collapsed at all, that means that you should restrict your fluid. If it is less than if it is less than 1 centimeter and totally collapsed, that means that you need fluid. But in between these values, there you shouldn't do anything relied on the IVC diameter and collapsibility indexes. But if you have to do it, please use the distensibility index, not collapsibility index. Distensibility index, you will use max minus divided by mean. Collapsibility index is max minus divided by max. So that doesn't mean anything because it has been studied hundreds of times. So you should change your formulas to the distensibility index when you have to evaluate IVC measure.
Okay, if
Yes.
anyone has any more questions, you may use the chat box to ask or use the Q&A section.
Okay.
We'll just wait 1 more minute. If no one has any questions, we'll be closing.
Naveen, 1 second. It was a great session as usual, Dr. Erol, my very close friend who has his heart and soul towards teaching the ultrasound to the emergency physicians across the world. It was very, very great to hear from you. And most of the residents, whenever hear your lecture, they always cherish it. And they have that moment that they're into the ultrasound and they get the most of the ultrasound to be done in the emergency department. And your programs, whenever it is done in India, it is taken well, and many of them come attend and they will learn about emergency medicine ultrasound, how the ultrasound becomes the stethoscope in the emergency department. Thank you very much from our heart. I thank Yashoda Hospitals and I thank my dear friend Dr. Erol for this excellent lecture.
Thank you very much for having me here. And also, I would like to extend my appreciation to Saravana Naveen Nimmala, the moderator of us. And I love you. I love you. I love all these Indian distinguished doctors, my brothers. Thank you very much. And I'm very honored. I feel very honored to be with you, and I am ready to give more presentations when you need me, and I am ready.
Dr. Azim, you may. 1 minute. He wants to speak. Let me. Yeah, Dr. Azim, you can unmute and talk.
Thank you, sir, Dr. Ramesh, for letting me to give my feedback to Dr. Erdogan. It is an excellent and amazing session taken by the Dr. Erdogan on the fluid management and the POCUS. I have learned a lot, and thank you, Sir Ramesh, for arranging such a vibrant session. And this is from the core of my heart, and it should be respected in the full spirit that you are doing a great job for the cause of the emergency medicine. Thank you, sir.
Okay, so before we close, how how do you pronounce your last name?
My last message.
Is it Unlash or Unluer? How do you pronounce it?
Erol,
Your name, total name.
Erol Unluer. Erol.
Okay.
Er-
Okay. Thank you so much for joining us.
Thank you very much. Thank you very much, everybody. See you. Bye.